just taking the few cases, which is very, very interesting. And I come across these type of cases in last 2-3 years. So this is a 32-year male patient, HIV 2012, ART, AKT for pulmonary TB for the same. He has a history of bronchoesophageal fistula, aspiration pneumonia in 2013. He was treated conservatively. He was lost to follow-up as our old patient. So in 2018, he was lost to follow-up. ART was stopped. Nothing was done. So he presented now in 2023 with the vitals, SpO2 was 84, tachycardia, X-ray shows right gross pneumothorax, and he was referred by ID physician to us. So he has a background history of cough with sputum, 10 kg weight loss, breathlessness, and X-ray and CT scan was done. This was the CT scan. You can see the right side pneumothorax, left side cavity, multiple, right lower lobe also cavity. So it's a clear-cut case of right pneumothorax with some lung infection. Mainly we are dealing with on background of HIV, it's a TB. So ICD was inserted, patient felt better, repeat chest X-ray done, which was better, CD4 count, viral load, everything was done. Sputum, as usual we see for the gene expert, all stain, routine culture, everything turns out to be negative. So this was the post ICD X-ray. You can see the lung is expanded and thick wall cavity in the right side and some few cavities on the left side. So bronchoscopy was done because sputum was negative. What we are dealing, we don't know. So BAL again, gene expert negative, all stain negative, galactomannan slightly positive, TBLB suggestive of just chronic inflammation. So what to do? So ID and pulmonology sit together and they started on AKT because background history of HIV. And BAL AB culture and fungal culture was awaited. So this was the CT scan. You can see the lung was expanded. The cavity is there, remaining cavity. So BAL, AB culture, fungal culture at 15 days came negative. ICD was claimed removed. Patient again has pneumothorax. ICD reinsertion was done. And we thought we are dealing with something else. So we review the biopsy with other center and just TBLB came as PCP pneumonia. So remind me you all, always in HIV there is not a TB. Even a cavity presentation is of PCP pneumonia. They have a very varied presentation. So we stopped AKT, we started on anti-PGP treatment. He has recurrent pneumothorax, twice pneumothorax, so we did a betadine fluorodesis. This was the X-ray, you can see, lung is expanded. This was the again pneumothorax, so we did a fluorodesis, and this was the final X-ray. You can see the cavity and everything was disappeared with the trimethoprim and sulfamethoxazole treatment. So PCP is very common in HIV, solid organ transplant patient, end-stage liver disease and kidney disease patient, chronic steroid taking patient, particularly COPD and asthma patient. How will you diagnose? Clinical samples. You can do a serum beta-D-glucan, which is an indirect marker of PCP as well as fungal. You can do a microscopy and various stains. You have to tell your microbiologist and pathologist to run this PCP stain in the samples. And at the last, you can do a PCR for PCP in samples. These are the various radiological presentation. It is a diffuse ground glass central opacity with peripheral sparing, sometimes a consolidation, and at the late stage, they have a small cavity and then it turns into a big cavity and lung destruction. Second case, which is very, very important, 48-year female, cough with yellow sputum, high-grade fever for just 5 days duration. But the background history was very, very important. She had a choking sensation while she is taking her Ayurvedic tablet for relieving her constipation, which she consumed regularly. Vital stable, blood investigation shows leukocytosis and high CRP. CT scan was done, which is suggestive of right lower lobe collapse. So I will show you the video very quickly. So we put a bronchoscopy. There was a high suspicious of foreign body. So we did a bronchoscopy in this patient. You can see the bronchoscopy video. Left side, everything is clear. Right side, you can see this is the Ayurvedic pill, which is in the right intermediate bronchus, completely occluding the lumen of right lower lobe. And you can see it is just nicely plasticity. Airway is just plastified by the chemical reaction of this Ayurvedic tablet. So why this is very important? Because when there is a chemical reaction because of the tablet, it will produce a very weird complication in the airway. This was the bronchoscopic video. Once we remove the foreign body, you can see still there is a remnant on the yellowish stain in the right intermediate bronchus. Right lower lobe is open. But this type of patient is very, very important. We have to follow this patient. You can see the 15 days later, there is a stricture in the airway. The 15 days later, the bronchoscopy, patient symptomatically better, but still some wheeze. So we repeat the bronchoscopy after 15-20 days. You can see the airway. Almost it is like sloughing of the airway in the right side because of the chemical content of the tablet. So what we do a serial balloon dilatation in this type of stricture, and we follow the patient. After 2 to 3 dilatation session, patient is absolutely fine and airway is almost regained. This is the final outcome after the all airway treatment with the balloon bronchoplasty. This is the left side. And this is the right side. You can see the airway is almost like recanalized. Some residual stricture, otherwise all opening is okay. Right middle lobe, lower lobe, everything is okay. So now we move on to the next talk. So it's about EBUS. As Yagnesh is mastering the conventional TBNA procedure. So we generally now almost obsolete because we have a facility of endobronchial ultrasound. So it is the tool to look beyond the airway, to assess the integrity of the airway, to sample the mediastinal lymph node, central lung tumor, peripheral lung nodules. So this is the dedicated EBUS where the needle is coming from the 45-degree of the angle, and there is a ultrasound transducer in the tip of the bronchoscope. So you can visualize that lymph node. There are 2 types of EBUS. One is convex probe, second is radial probe to take out the biopsy from the mediastinal lymph nodes and solitary pulmonary nodule. So we have quickly 1 or 2 cases. How it is different from normal bronchoscope? The diameter is little bit high. You have a 60-degree view where the normal bronchoscope has a straight view. Endoscopic image is good quality in normal bronchoscope, which is poor in a EBUScope, and you can take sample the lymph node real time. So these are the lymph nodes. We can take access through the EBUS. Most of the lymph node you can access through the EBUS except patient station 8 and station 9. So there are 2 main indications of the EBUS. One is the diagnosis of mediastinal lymph nodes and centrally located mass, and it's the standard of care for staging the lung tumor before doing the surgery. So let me begin with the case. This is the 38-year male patient, known case of CA glottis, total laryngectomy on permanent tracheostomy, no symptoms. PET scan was done just for the surveillance, which shows the right lower paratracheal very small lymph nodes. So we passed the endobronchial ultrasound through the tracheostomy. This is, you can see the bronchoscopic image is little bit poor. Now we see the lymph nodes which is sitting in the above the SVC. This is the SVC, superior vena cava. This is the lymph node. Then with the real time, as our ultrasound, we pass the lymph node needle. Same needle is passing like through the working channel of the bronchoscope. It's a dedicated EBUS needle. We take the samples from these lymph nodes. And this rapid on-site, as Yagnesh mentioned, is came as granuloma with necrosis. Gene expert is negative. Finally, AB culture is positive. So here the EBUS has changed the management. Patient is known case of cancer and it came as tuberculosis. And patients, we started on AKT and he is absolutely fine. Second case is the cardiology and EBUS. Is a 48-year female with twice history of cardiac arrest due to ventricular tachycardia and ventricular fibrillation and sinus pause. Is a malignant erythema. Blood investigation, everything is normal. You can see the ECG. There are different ECGs of the patient. This is the asystole. So they treated with CPR, cardiac shock, everything was done. And then finally they started doing the workup of the patient. So cardiac MRI shows some abnormality in the apical wall of the myocardium. PET scan was done also for the find out the systemic cause of these malignant erythema. It shows bilateral lung diffuse nodules and high uptake mediastinal lymph nodes. So these are the lung nodules. So what we did? So we did here the EBUS. So EBUS from the mediastinal lymph nodes, subcarinal lymph nodes. But the EBUS rapid on-site evaluation shows only a scanty tissue. Sometimes it will happen. So what we do? We puncture the bronchial wall. We pass the cryoprobe through the node, and we took the nodal biopsy as well as the cryolung biopsy. Cryolung biopsy is the freezing the lung tissue with the cold treatment, and we took the better chunk of the mediastinal lymph node as well as the lung nodules. So we are just locating the lymph node. This is the right lower paratracheal lymph node. This is the SVC. This is the subcarinal lymph node. First we took the pass with the needle. This all is real time. You can see the needle. This is the needle. Jabbing of the needle through the across the node. But the rapid onset shows the scanty tissue. What will happen? So then we convert this into the EBUS cryonodal biopsy. So what we do, we just puncture the needle site, and then we use the electrocautery, and we make a hole in the wall of the bronchus. So we activate the electrocautery pedal. This is the hole in the wall of the bronchus. You can see the big hole. With that big hole, the cryo 1.1 probe go inside the node. So we are doing more jabbing and producing the track. And then you can see this the cryo probe. So we can take a cryonodal biopsy. Why it is important, we'll just see in the next lecture. So this is the cryo chunk. You can see the tissue is big. With the FNA, you can take just the core, but with the cryo, you can take a big tissue. So these are the tools to target the mediastinal lymph node. You can do a conventional TBNA, as Yagnesh mentioned. You can do a EBUS TBNA, you can do a forceps biopsy, or you can do a cryonodal biopsy. The yield of EBUS TBNA is high in lung cancer and TB, but when there is a suspected sarcoidosis or a lymphoma, the yield goes down to roughly around 50 to 80%. So this type of patient required a cryonodal biopsy. In lung biopsy also we took is a modified version of TBLB where the tissues are very big, and we just freeze the lung tissue. You can see the difference of the tissue. This is the normal lung forceps biopsy, and this is the cryo biopsy. This is the chunk of the tissue of the cryo lung biopsy of one of our patients. So this is a 47-year female patient, was asymptomatic. PET scan was done because background history of CF breast, which shows the right hilar lesion, but the right hilar lesion is just nearer to the pulmonary artery, you can see. So what we can do, so this is the video of this patient. You can see the pulmonary artery is sitting just close to the mass. So we can puncture that artery. It is described, and the technique is called transvascular needle aspiration. So we can puncture the needle through and through the vessel, and we can take the biopsy. It is little bit risky, but with the experience it will come. We have almost around 20-30 cases of transvascular needle aspiration so far without any complication. The technique here is you have to through and through puncture the vessel. You cannot keep your needle inside the vessel, otherwise you can aspirate the blood so many and patient may have a fatal hemoptysis. So this is the needle. You can see the needle is nicely inside the mass, and it is finally came out to be a malignancy, and tissue was also adequate. This is the 50-year female, not a smoker, left-sided chest pain for 20 years. Chest X-ray normal, CT thorax suggestive of just an SPN in the left lower lobe. You can see this is the solitary pulmonary nodule. Any opacity less than 3 centimeter, no collapse, no pleural effusion. It turns out to be a SPN. So bronchoscopy was already done outside. Everything was inconclusive. Patient referred for percutaneous biopsy, but because this lesion is located in the center, radiologist explained pneumothorax and patient refused for that. So what we did, we did a PET scan. We see what is happening. So PET scan shows only localized lesion, no other lesions. So what we do a radial EBUS in this type of patient, which is another form of endobronchial ultrasound, where we locate the lesion in particular segment when there is no endobronchial abnormality. So we passed a specialized radial EBUS probe through the working channel of the bronchoscope, and we locate the lesion in particular segment. So these are the left lower lobe various segments. These are the various segments of the left lower lobe. So it is located in the one of the end. So superior basal segments. So this is the lateral. So you can see there are a lot of subsegments. So then we pass the specialized probe of the radial EBUS, and then that radial EBUS created the image. So we pass in all the segment. You can see this is a well concentric image. Just the mass is located in that particular segment. Then we take out that probe. We mark that probe in our cryoprobe, and then our cryoprobe goes to the lesion and it take out the biopsy. With the same setting, rapid onsite came out to be a malignancy. So we do the mediastinal staging. We do the convex EBUS. All the lymph nodes have to be staged. And if all the lymph node is negative, then we refer the patient for lobectomy. So TBLB suggestive of malignancy, EBUS TBN confirmed, adenocarcinoma material was adequate, and patient referred to thoracic surgeon for lobectomy. So this is all about the diagnostic advances, radial EBUS, convex EBUS and everything. Now we move into the therapeutic interventions. I have only 2-3 cases now. This is a 25-year gym trainer. Here the sequence of the event is very, very important. Just be on the slide. So this patient is February 23. He had a fall down history. Elective tracheostomy was done. GCS was improved. He went off from the ventilator on 13th of the February. Decannulation was done on March. So 1 month event. He had developed a cough and dyspnea while taking both solid and liquid foods. So we are dealing with some kind of fistula. CT and barium confirmed the fistula TOF, which was later confirmed by upper GI and bronchoscopy. And the first bronchoscopy was performed. So the gastro colleague has put a stent and fistula was almost closed. But when the patient was ventilated at that time, they planned to put a ET tube, which was very difficult to pass. So he had some stricture above the level of tracheostomy. So esophageal stent on in situ, tracheostomy on situ. Patient offered a surgery because it's a benign fistula. So at our center, ENT, gastro-thoracic surgeon all together performed a surgery. So TOF repair was done. Surgery was uneventful. Esophageal stent was removed. He underwent a cranioplasty because bone was not there. Follow-up upper GI scopy again shows the fistula. So surgery is failed. So he has cut down a little bit of trachea also. So again patient was on tracheostomy. So what this was this bronchoscopy when the patient came to us. So you can see there was a grade 4 stricture in the trachea above the tracheostomy. Even nothing was passing from here. It's completely seal off, grade 4, 100% almost gone. Then we see the fistula also. You can see the fistula, and we pass the bronchoscope into the esophagus and see the fistula from the esophagus side also. So we tell patient nothing will happen. You can you can go to the Delhi, Hyderabad, Mumbai, whatever you want. I have given him my address. So everywhere all the options was explored because the trachea, the length of the trachea was not adequate. So surgeon was not happy to do that end-to-end anastomosis and repair again. And somebody has explained a tracheal transplant also. Then patient was a little bit scared. So meanwhile, I told you just observe and see. We'll just do a bronchoscopy, check bronchoscopy after 3 months. You just keep the tracheostomy tube in situ. So after 3-4 months, the fistula is completely healed off, which was confirmed in the CT and barium. This was the fistula. So almost healed. So now what to do? How to get rid of the tracheostomy? So to get rid of the tracheostomy, what we did is we just open up the stricture above the tracheostomy scar. Otherwise, patient is on permanent tracheostomy for lifelong. So this is the rigid bronchoscope. We pass across the vocal cord. The fistula is healed. We again examine also. So now the patient has to get rid of this grade 4 stricture. So what we do a retrograde tracheal dilatation. So first we pass the rigid, then we cut the stricture, and then with the artery forceps, we go through the tracheostomy tube and we do the retrograde dilatation of that stricture, and you can see we make a trach. So one track is from the tracheostomy and second track is from the trachea. So then we just cut this, cut more the stricture. And then we do the balloon dilatation of this stricture to make it more enlarged. So this is the CRE balloon dilatation. This balloon is going from that stricture. So we opened, we just went inside into the trachea. So this is the dedicated control release expansion balloon. So we dilate the balloon for 30 to 60 seconds from different diameter. We start from 10, 11 mm to 15 mm size balloon. So we dilated, and then you can see this is the tracheostomy scar and this is the trachea. We reached up to the carina, you can see. So trach is made. Then we pass the rigid bronchoscopic barrel to make it more widen. So our rigid barrel is going. And then we put a silicone stent, which is a specialized stent. This is the silicone stent. So that this stent is more comfortable to the patient. We can keep the stent for 1 year, 2 years, up to 3 years without any complication. So we now just adjust the stent. So patient is get rid of the tracheostomy after 2 years of marathon. So this is the stent. You can see stent is nicely placed below the vocal cord up to the carina. Then we put the stitch on the stent to fix the stent because there is a chance of migration. So from the neck, we keep the stitch there. So this is almost a 2 to 3 hours job. So these are my happy patient. If you allow, I can take only one case. Okay, thank you. So this is a 55-year male, no comorbidity, no habit, presented to us with respiratory distress and hemoptysis. He had a background bronch done, tracheal tumor, suggestive of adenocarcinoma. When he came, his vitals was stable, but he was orthopnic and history of 100 to 200 ml of hemoptysis. This was the CT scan. Why I am telling you about this case, there is a lot of advancement in the lung cancer. So you can see the large tumor in the right lower paratracheal region. It is going inside the trachea. Multiple mediastinal lymph nodes occluding the lumen, around 70 to 90% of the tracheal lumen. You can see the lung window. He has a lymphangitic carcinomatosis, diffuse bilateral lung nodules, streak of bilateral pleural effusion. So it's a clear-cut case of stage 4 lung cancer. So before 10 years, this type of patient, we tell you go and expect. There is not at all any options. But nowadays, there is advancement in the intervention. There is advancement in the molecular analysis. You can almost cure this type of patient. So what we did, we just get rid of these patients. First, the symptoms. Patient presented with stridor, not able to lie down. We pass the rigid barrel. So this is the rigid bronchoscope. We passed across the vocal cord. You can see the tumor is sitting, bleeding. This is the tumor almost occluding the lumen of the trachea, like 80% of the normal lumen. So with the rigid barrel, we just core the tumor. So this barrel, with the bevel end of this barrel, the tumor is cut from the base. So we are trying that. And every time we have to check for the hemoptysis, whether any bleeding is there or not. We have to keep everything alert. Thanks to our anesthesia team to support us, because otherwise it's very difficult. We have to share the airway with the anesthetist. So this is the tumor. We try to take out as much as we can take those tumors. So you can see a pretty much amount of bleeding. So we can keep the rigid bronchoscope there as a tamponade to control the hemoptysis, and again we have to start operating on that. So with the small barrel, it was very difficult to take out there, so we have changed the barrel. We take out the 12 size barrel and then we again re-intubated the patient with the 14 size barrel. So this is the another barrel we passed. It's a more larger diameter barrel, 14 size barrel. So it was very difficult with the 12 size barrel to take out the tumor. So once the tumor is taken out, you can see the significant extranumeral compression. So before putting a stent, we have to go beyond this stricture with the barrel, and then we try to go with the barrel and taking out the residual part of the tumor. So now our barrel is reaching up to the carina. Just 1 minute. Then we put a silicone stent in this patient because there was a lot of extranumeral component. So now my barrel is at the level of carina, so we can put a stent there to treat the extranumeral component. This is the stent here. You can see stent has almost covered the stricture part. Tumor is removed. Patient is extubated on table. No more hemoptysis. And it finally came out to be adenocarcinoma. He received first cycle of chemo. And meanwhile, molecular marker came as BRAF positive. So BRAF, there is a treatment which is called a Dabhi, Efenib and Tramatinib. So we initiated our oncology on this treatment. 1 month follow-up, you just see the CT scan. You don't believe, the CT scan is almost, video is not running. CT scan is almost changed. All the lung nodules go on. The stent is nicely on CT. The nodule is not seeing. Effusion is gone. Mediastinal lymph node size is decreased within a 1 month of treatment. And patient is completely asymptomatic. So we removed the stent. Now patient is on this molecular treatment. So this is how it changes the management. Thank you. I will not discuss last case.